Gillian, for the kind introduction. So it's humbling to have the chance to speak in this environment, especially following the current lecture. I will try to give you a little bit of a glimpse of the experience we've amassed over the past few years at Princess Margaret Hospital. It's not in the same scale as the work that's been happening here, but I think in many ways, through different pathways, we're arriving at very similar conclusions. And so this is a perfect venue to compare these data and these results so that we can move forward. So what I'm going to talk about today is the challenge of tumor targeting. We have an understanding, I think now, that we need to do a better job of improving the radiotherapeutic ratio in prostate cancer. We cause too many side effects in patients who are overtreated and undertreat patients who need more treatment and can't seem to strike a balance in anybody. And one of the strategies, obviously, would be to do a better job at tumor targeting, both in diagnostics, prognostics, and in delivering our treatment. This is supported by a number of publications. And there are ongoing prospective trials. You just heard of one. The two randomized ones that are ongoing, I'll point to as the biggest one is the FLAME trial out of the Netherlands. It's a randomized trial where patients are all getting 77 Gray and 35 fractions of the prostate, half are randomized to an integrated boost to 95 Gray. Their sample size is big, as you can tell. It's 3 different institutions, and they have now completed accrual. So we can expect that they will report at least on early toxicity data within the next few years, which will be very interesting. And their primary endpoint will be biochemical control. So it's not going to be too long before we have some answers about PSA response with this strategy. A much smaller single institution trial, but nonetheless randomized. It comes from Alan Pollack, not surprisingly. And he's giving, the standard arm is getting 80 Gray to the prostate, the interventional arm is getting 76 Gray to the prostate with an integrated boost to 90 Gray. And the contrast here is that their endpoint is a biopsy at 2 years. So although it's a smaller trial, I think having a biopsy endpoint will be also very informative in terms of sites of local recurrence. I highlight 2 ongoing phase 2 trials. They're simply going to add to an already relatively large bit of literature on tumor boosts in single institution series. The Delineate trial out of the Marsden has completed accrual, and it's a very modest dose escalation, as you can tell. They've moved on to a hypofractionated regimen and are testing that now in the next phase of their trial, and their endpoint is biochemical. And then, so I'm going to tell you a little bit about our early experience with our trial. In our trial, patients who are planned for the definitive radiotherapy for prostate cancer are screened with an MRI, and if they have a visible nodule on MRI that's consistent with their underlying trust path, then they're eligible to participate, and that's regardless of their risk group. The only caveat is that we allow 6 months of hormones in those patients that the physician feels that hormones is indicated, but not longer than that. And patients get to choose, or their physicians get to choose between the assignment of 2 arms. The first is VMAT integrated boost, like we just heard. And the second is an that's the bottom one. And the second one is an HDR boost to VMAT. So when we do dose comparison between the 2, the organ asterisk exposures were the same, and we picked doses to respect that. And the minimum dose of the tumor is the same when you do your RB calculation, but as you can imagine with HDR, you get a much higher integral dose to the tumor. So I'm going to talk about 2 challenges. One is targeting tumors with needles, and the second is how you target tumors with radiotherapy. Our program has been invested in a platform for MRI-guided needle insertion now for upwards of 8 years. It's been done in collaboration with Hologic Medical, now in vivo. And it's basically a tabletop solution where patients are positioned in the frog leg position. For those of you who haven't seen this yet, they're under anesthetic. In this case, it's propofol sedation. So they have a laryngeal mask. They're not ventilated, but they're sufficiently sedated to keep them as immobile as possible. As you can imagine, without paralyzing a patient, you can't guarantee that there won't be motion problems, but that's as far as we were willing to go in terms of the invasiveness of the anesthetic, which is plenty invasive for a biopsy procedure. Everything is done in the MRI scanner, so this is a Vario 3T hung up on rails, so it's officially an IMRIS system. And so the user, as opposed to being in a different position that we're all accustomed to, works from the top and from the side of the patient to insert the needle. And the system is very akin to the transrectal ultrasound systems that have a transperineal template affixed perpendicular to the system. And so it's basically a stereotactic system that assumes that the device doesn't move in space relative to your target over time, which is why the immobilization is so key. So the target trial is the one I'm going to talk about first. It is supported by Canadian Cancer Society. This is the identifier on clinicaltrials.gov. The sample size objective is 80 patients, so to date was actually accrued 30, but I'm showing you data on the first 28, initiated 2 years ago. I've talked already about the eligibility. So far, the mean age of our patients has been 66, ranging from 51 to 75. And strangely, the arm assignment has been exactly equivalent between HDR and VMAT. And some of it's been physician preference, some of it's been patient's preference. And I have to admit, when patients have a preference, they tend to push hard for this solution because they've heard that HDR boosts are a good idea and they're interested in an HDR boost approach. So I'm sure there's a complex interplay, but basically they're neck and neck in terms of acceptability within the department. Our primary endpoint will be a biopsy at 3 years. So we're very invested in spatially mapping the tumor up front and the tumor at recurrence so that we can understand whether the geography of our intervention makes a difference, and if an error in the geographic targeting is present, whether that contributes to failure as opposed to the underlying rationale. So at baseline, all of these patients are getting an MRI-guided biopsy of their tumors to confirm the targets. And we do that at the same time that we insert 3 fiducial markers. The markers are useful for us for image registration to CT, and they're also useful for daily guidance. Even though we have daily cone beam CT, we can be a little bit tighter on our PTV margins using the markers in our experience. So it serves 2 purposes, and we integrate both in the same session as well as our endorectal coil imaging for treatment planning. So when we look at the impact of this step, which is not a standard step at all when we plan radiotherapy, first of all, the majority of patients did not have a prior MRI before they stepped in the door, and that's typical of our population. There was only 6 that had a prior MRI. And we found majority of patients being upstaged, and that's not surprising. The majority of the upstaging was in fact from T1C to T2, because all of a sudden we had a nodule visible in MR. So it's very much a stage migration phenomenon. But what was a little bit different is that 5 patients were upstaged to T3A, and that certainly was not expected. Now, it's not overwhelmingly gross extracapsular extension that you would have felt on a digital rectal examination, but it is definite extracapsular extension on MRI, and I'll show you some data in a bit to demonstrate how important that information might be in terms of prognosis. We have 2 patients that were upgraded to Gleason score 8. So there were other upgrades from 6 to 7, but the only clinically significant one was this upgrading to Gleason 8. So specific tumor targeting did, in a minority, small cohort of patients, upgrade them. And then in 6 patients, we went from 1 to 2 targets for the tumor boost. Nobody came in expecting to have 2 targets for tumor boost. So I've already hinted at this data. There's at least 3 publications here indicating that the presence of extracapsular extension on MRI is prognostic in terms of outcomes after radiotherapy. This is for external beam radiotherapy, and this is for brachytherapy. So clearly, it's a prognostic factor, and the question is it a prognostic factor that's indicative of underlying biology, or does it raise a little bit of a flag about our targeting strategies? And with very small PTV margins and prostate targeting, the risk that we may be missing some extracapsular extension of tumor in some cases, leading to this poorer outcome. There's one other publication that I'm aware that looked at the impact on staging at the time of radiotherapy planning in patients who are headed that way. So this is a group that looked at extracapsular extension and seminal vesicle invasion. So upfront, when they came in for their simulation, 32% of patients had extracapsular extension, and after they had their MRI simulation, that went up to 40%. The biggest difference here was the seminal vesicle invasion, which went from only 1 patient up to 21 patients, so 18% of the cohort. So others are, not surprisingly, finding that the more you look, the more you find, which may have an impact, obviously, on management. I'm showing this example from the target study. It's an anterior, very anterior central zone tumor. And those we used to think, or at least I used to think, as the exception rather than the rule. They are definitely present, but they're not the majority of patients that we see. When we looked at our data, that's one of the surprising findings. Half of the tumor targets that we saw and treated were the anterior central gland. And that's very different from what I was taught when I was a medical student, and very different from what's in the literature that's led mostly by a truss-guided biopsy approach that tends to bias the pathology to a peripheral sampling technique, and hardly ever, if ever, will sample any tissue behind the urethra here at the top. So that's a completely different distribution than we appreciated in the past. It's actually good news because you think that boosting this surely is easier than boosting something back there. So it's a little bit of a sigh of relief for the mechanism, but it's something that to be sort of aware of moving forward. We had 44 suspicious lesions in those 28 patients, so roughly well-distributed left to right, majority in the mid-gland, but again, some at the apex and base. And about 40% of them were less than 1 centimeter in diameter. The range was 0.5 to 2. Now, we were able to confirm 32 of these lesions based on the MRI-targeted biopsy. They were distributed as such, so we only targeted PIRADS 3 to 4, obviously. And PIRADS 5 lesions, there were 3 of the 17 PIRADS 5 lesions that were negative and I've qualified as false negative, and I'll show you why. So I think we have 3 false negatives in that group. We have 6 patients with lesions with PIRADS 4 that were negative. Half of them, I think, are false negatives. And then we have 4 PIRADS 3 lesions that are negative. One of them, I think, might be a false negative, but that's unclear. So I don't know the right answer, and I'll tell you why I'm raising this possibility of a false negative, because if I use biopsy as the gold standard, I don't have that information. And it's interesting, in discussions with the UK people, they also started doing biopsy confirmation of their targets, and very early in the trial, started to realize that they believed the MRI more than they did the biopsy. Now, the biopsies were done under ultrasound, and it was a cognitive fusion between the MRI and the ultrasound. So the target miss was ascribed to a registration error or human targeting error. But nonetheless, they started to believe the MR more than the biopsy. And I'm starting, in some cases, to believe the MR more than the biopsy, and I'll show you why. So Aaron's already seen this slide. I've shared that with him because we have some data that is interestingly similar. So this patient has a sub-centimeter lesion in the very lateral aspect of the right peripheral zone. It's hypointense on T2, surrounded by bright signal. That's circumscribed as they get. So this is a good case example. We always target center. Why would we target anywhere else in our coordinate system? And what we've started to observe is this happens a lot, that we see the needle void. This is a biopsy needle void that we take on every volume image. It's right at the edge of the tumor. So it's targeted right, but it ended up at the edge. Now, did it randomly deflect there? Who knows? We take a sample, and it's a negative sample. We do it again, and it deflects again, this time a little bit more medially, but again at the edge of the tumor, and this sample was negative. We did it again. This time it deflected a little bit more laterally. You can see that it displaced the capsule a little bit, and again a negative core. This one didn't have prostate tissue in it, so clearly the needle was just outside the prostate capsule. And it's only the 4th time when you see and you convince yourself that the needle void is surrounded by dark tissue, so it's in the tumor, that we ended up with a positive core biopsy. This is not an exceptional case. It's just a very clear one for presentation. But when we looked at our data, we had 82 cores, and 70% of those cores had what I called marginal tumor targeting, so this needle void right at the edge of the visible tumor. And when we compared the performance of marginal cores versus central cores, the negative rate in the marginal cores was 40%, and in the central core was 10%. So I think that's data that supports my hypothesis that the tumors are deflecting the needles, and that the deflected needles at the edge of the tumor have a high risk of being falsely negative, or appropriately negative if they've missed the tumor. The mean tumor, I think this is the other way around. Yeah, marginal cores were, sorry, this is an error. So marginal cores were more commonly found in smaller tumors than in larger tumors. So it was a lot easier to get a needle at the center of the tumor in a larger tumor. So if we only had one sample per target, and we were sort of in a bit of a time pressure, the original plan, because it's such a targeted biopsy, was not to do a lot of sampling. In fact, the ethics protocol had limited us to 4 cores, and when you have more than one target, there's only so many cores you can take. So we had about, I would say 40% of our targets that only had one sample. And if you only had one sample, the chance that you were negative was 50%. If you had more than one sample for any given target, the chance that you were negative was only 12%. So the number of cores, obviously it's not as simple as that. There's a relationship to tumor size, et cetera, and PIRAD score, but there's sort of some general trends that we can appreciate here. One of them is that because of this needle deflection, especially in small tumors, you need more than one sample to convince yourself that you have a true negative outcome. Obviously, we know that the needles deflect. We did this analysis in our original cohort that I'll get to in a second, looking at, compared to the intended target in the MR coordinate system to where the needle void actually went. We have a systematic bias posteriorly, and we know this. We see this in ultrasound-guided transperineal implant. And that's virtue of the fact of how the needles hit the prostate and get deflected a little bit posteriorly as they hit that resistance. But otherwise, there's sort of a systematic and non-biased distribution right to left. The distribution is relatively wide, so this has nothing to do with the tumor. You can expect some needle deflection, obviously, but you wouldn't expect that needle deflection to always land at the end of the tumor if it was a completely random event. We're not the only ones who are trying to do biopsy confirmation of boost targets. This is another recent publication in urology, but it does sort of raise the question of the intent is to be better than MR, but the biopsy itself, if it's not done properly, may end up being worse than the MR because of this targeting issue. So we'll talk now about targeting tumors with radiotherapy. So this data was published in Radiology, and it looked at a cohort of patients that had locally recurrent prostate cancer after radiotherapy. So it's a completely separate group of patients, and we chose to begin with them because the burden of a salvage intervention is obviously much higher in this group of patients, and we thought that testing the concept of tumor targeting in them probably made more sense as a first step. We set out again to show that MRI was great and we didn't need biopsy to do focal therapy in recurrent disease. We looked at the performance of MR in terms of sensitivity, specificity, negative predictive value, and positive predictive value. And again, we're talking about a multiparametric approach, T2, dynamic contrast, diffusion weighted, 2 observers, each with adding a 5 millimeter expansion margin. And what we found is that our results were very comparable to what's already published in the literature. The overall sensitivity rates with the multiparametric approach, depending on the observer and with the addition of an uncertainty margin, were around 80%, mainly stemming from reduction in negative predictive value. The specificity was quite high. But we took the targeted biopsy paradigm in that group a little bit differently. Instead of just confirming a target or a lesion, we wanted to confirm the boundary of the tumor, whether or not what was segmented manually by an observer was corresponded to the underlying pathology. And so we did 12 core biopsies, mostly targeted to the tumor in a radial fashion, and then co-registered the biopsy targets, so you can see the needle voids here, back to the original T2. So the red dots are voxels that we think are sampled, and red being malignant. The green dots are voxels that were sampled and being benign. So in this top case here, you see that there was a tumor segmented on the ADC in this case, but we used multiparametric, just showing one parameter. And this was sampled, and it was found malignant, but it completely underrepresented the overall extent of the tumor in that malignant cores were found laterally all the way to the edge of the prostate gland. This lesion here was found by only one observer. It was very small, and all of the cores here are negative. Now, either we missed it because you can see that they are marginally targeted, but there were a lot of them. There were at least 3 that were right at the edge, and a 4th one a little bit more posterior. So we did, in the end, because it was multiply sampled, consider this a false positive. But we have this false negative core here. So this core had 5% microfocus of cancer, nothing you would ever expect to see on an MRI scan, but nonetheless expressed evidence of disease. I'll bring this case back in a little while to show you why this might have been relevant. So we ignored this, but we extended our tumor margin to include the lateral extent of the tumor. Other cases, just ruling out false positives. So in this case here, multiply sampled felt to be a false positive. And in this case here, there were 2 samples, 1 negative at the margin, I suspect, and 1 positive within the tumor. When we looked at the contribution to the final tumor volume, we found that volume-wise, each of these modalities were similar, but the multiparametric approach ended up with tumor volumes that were twice the size of any of these modalities by themselves, which is not surprising. And obviously, the expansion of a 5 millimeter margin increased volumes even more. But we had 19 patients that not only did we have the segmentation, but we had ink marking at the proximal end of the core, so we could determine in a soup-in fixed stent where the malignant voxels should be. And then we found that if we only used MR alone, including both observers, that the MR without biopsy would have done the job accurately in terms of delineating the tumor in half of the patients. If we added a 5 millimeter expansion margin, that went up to 63%. And if we went to a targeted biopsy, that went up to 89%, predominantly for extending the boundaries of the tumor. So tumors were voxels were positive beyond the segmented boundary, beyond the 5 millimeter expansion, and resulted in a further expansion of the tumor volume. We have 6 patients that have gone to radical prostatectomy, so you guys have a lot more data than we do, but in the salvage setting, this is quite precious data because they don't often go for salvage prostatectomy. And what we found in those patients is that in every case, we identified the tumor, the IDL, and in every case, we represented the extent of the tumor. So we under-contoured in every case, even with a 5 millimeter expansion margin, which, with the exception of this case here, CP4. We also found that 3 of the 6 patients had these tiny little microfoci distant to the tumor that you wouldn't have expected to see on imaging and are of unclear biological significance, but nonetheless were present. So how do you delineate tumors? If you're going to try to deliver radiotherapy or any other energy deposition, clearly you want to do a good job at defining what your target's going to be. And we're not the only ones who have thought about this. I'm just giving you an overall sample of what others have done. There's some excellent posters in the back that address the same issues. So one strategy is to simply auto-segment based on the threshold on the ADC map, but that's problematic because the relationship between tumor volume pathologically and on MRI with auto-threshold isn't perfect. But not only that, it's also dependent on the underlying Gleason grade, and it's also dependent on the underlying density of tumor. And so there's not it seems like it would have been an easy, probably too easy approach to segmentation. Other strategies would be to normalize to the normal or uninvolved peripheral zones. Some authors have shown an improvement in volume correspondence using this approach. You have to remember, there's some very elegant posters in the back talking about novel diffusion-weighted imaging techniques. The standard EPI, single-shot EPI technique, is on the right here, and we all know it's distorted, which makes multiparametric analysis challenging because even if you assume the patient hasn't moved, tracking those voxels is challenging, but also makes it challenging from the point of view of delineating tumors when clearly you end up with tumors that are simply outside the prostate gland as defined by T2, and you know that's not possible because it's extending into the endorectal coil. So one strategy that we've explored successfully is a segmented EPI technique. The cost to that approach is time. So this imaging sequence is twice as long as the one on the right, which is problematic if you suspect that your prostate will be moving during the acquisition. Less problematic for us with patients under anesthetic, so we've done all of these with patients under anesthetic, but clearly this approach, although geometrically sound, needs to be fine-tuned in order to bring down the scan time. Multiparametric voxel-based approaches have been explored. Others have, instead of giving a yes or no tumor approach, have suggested going akin to the nomenclature that's used in cervical brachytherapy, where you define not just a GTV, but a high-risk CTV based on probabilities of tumor based on a map. So that's from the Utrecht group. And then papers are starting to come out about how poor contouring variability is, and you guys have done that work as well with regards to tumor segmentation. So we have a problem. I don't have a solution. I'm only posing the challenge to this smart audience to solve. This is an example of a patient who was salvaged with brachytherapy, and our initial cohort had a whole gland implant with the distinction that they had a dose reduction to the uninvolved gland and a tumoricidal dose to the tumor. So in this case, we gave 11 gray twice to the tumor, 8 gray twice to the prostate gland. And what we found is that although in a lot of patients we saw this result, which is tumor disappeared and was biopsy negative after treatment, we also had a minority of patients that had this problem. So this is the same patient I showed you earlier with a segmented tumor here that we actually treated laterally all the way here and all the way to midline that failed. He failed infield, but he also failed marginally, probably in the area of that microfocus of disease that we excluded. So I haven't included data on our toxicity outcomes, but I can tell you that this treatment is very safe. It's probably too safe because it's not effective enough. When all of your failures are exactly where you knew the disease was, even if the failures are only 30% of patients, clearly we didn't give enough to the tumor. And so there's room to move, and that's the next cohort. So the next cohort now has gotten 13 patients accrued. We're just waiting for the 3-year biopsy data. And it got 13 gray twice to the tumor and no dose at all to the rest of the prostate gland. So we'll await eagerly to see whether our failures. This is with a 5 millimeter expansion margin on the tumor. I will, before we go further, there's been talk of, and I presented this just now, this concept of not just giving more dose, but also de-escalating dose where you know that disease burden does not lie. And this paper is probably the one paper that's raised the most caution and the most discussion about the perils of dose reducing in the uninvolved, quote-unquote, prostate gland. So this is a trial out of Michigan where they did urethral sparing IMRT. Apparently all had an MRI scan, all confirmed that the tumor was not abutting the urethra, created a low-dose tunnel along the urethra in their very sophisticated IMRT, did fantastic job with delivery and stopped early because of an interim analysis that showed this. So the urethral sparing arm had a far inferior biochemical control rate, and that scared everybody off. The dose de-escalation was to 64 gray, so it's a big dose de-escalation, although it's not that different from the old 66 gray that we used to give as a definitive dose. But obviously there's a limit to how low you can go and safely treat non-visible MR disease that we know is there in a real proportion of patients. The modeling data that's coming out now seems to indicate that limit is probably 70 gray. So I doubt if you want to maintain similar biochemical control rates to see anyone de-escalating beyond 70 gray in the standard fractionation 2 gray per day approach. That's all I was going to say. Thank you.